So after discussing tuberculosis, we shall have a brief discussion about the anti-leprotic drugs today. So leprosy, though incidence is little bit decreasing, but still it is quite prevalent in some parts of the India, and it has some uneven distribution. So after introduction of the multi-drug therapy, incidence dropped down from 57.6 cases per 10,000 population in 1981 to less than 1 per 10,000 population in 2005. So India has achieved elimination of leprosy but not eradication. So India has the largest number of leprosy patients in the world with almost 1.27 lakhs new cases in 2016, and it contributes to 60% of the global incidence, and 51% among them are multibacillary leprosy. So definition of multibacillary possibacillary leprosy you will be well aware about from the microbiology class. So Indian classification of the leprosy, it can be divided into 5 groups: intermediate, indeterminate, tuberculoid, borderline, lepromatous and pure neuritic. We are mostly concerned with the tuberculoid and lepromatous variety. And what is the objective of the treatment? Just like tuberculosis, our first aim is to make the patient non-infectious. So we can do that by interrupting the transmission. So to interrupt the transmission in community by sterilizing the infectious patient. Sterilizing means making them non-infectious as rapidly as possible with bactericidal drugs. And we have to ensure that early detection and treatment of the cases to prevent deformities, because leprosy, if untreated or detected late, that can lead to irreversible nerve damage and that can lead to deformity. So we have to prevent that. So first aim is to make them non-infectious. Second aim is to prevent deformity, and third aim is to prevent drug resistance. Okay. So drug classification, number of drugs is not very large like tuberculosis. So mainstay of therapy is dapsone, that is a sulfonamide group of drug. Clofazimine, that is a phenazine derivative. Anti-tubercular drug like rifampicin and ethionamide can be used as anti-leprotic drug. Among them, rifampicin is used in all patients almost, unless contraindicated due to other reasons. Other antibiotics like ofloxacin, moxifloxacin, minocycline, clarithromycin. So ofloxacin and moxifloxacin are from propioniol, minocycline is from tetracycline group, clarithromycin is from macrolide group. So these drugs can be used as alternative drugs when main drugs cannot be given. So first drug is dapsone. So dapsone is diaminodiphenyl sulfone. It is the oldest drug, cheapest drug, and still now most commonly used anti-leprotic drug. So it inhibits the para-aminobenzoic acid incorporation into folic acid by folate synthase. So dapsone, sulfonamide, so mechanism of action is same like sulfonamide, and it is leprostatic at very low concentration, but commonly at the therapeutic dose it is lepricidal, and resistance can be both primary and secondary. So unless patient is resistant to dapsone, it works very well in the leprosy. And primary resistance is due to means patient is already resistant before its use, and it is due to mutated folate synthase, or there can be secondary resistance. That means after some days or months of use, dapsone is become resistant. Half-life is more than 24 hours, and it is cumulative in nature, deposited in many tissues, and there is gradual slow release of the drug from the site. Adverse effects. So just like sulfonamide, we have to check G6PD status, glucose 6-phosphodiesterase status. If patient is deficient with that, that can lead to hemolytic anemia, and it is generally well tolerated at 100 mg per day dose, and rarely dapsone can cause methemoglobinemia, paresthesia, headache, fixed drug eruption, phototoxicity, exfoliative dermatitis, and much more rarely hepatitis and ankylositosis. But don't forget this G6PD deficiency status in such patient that can lead to hemolytic anemia. And sulfone syndrome, that is a hypersensitive reaction that occurs 4 to 6 weeks after starting dapsone treatment, and it can lead to fever, malaise, lymph node enlargement, desquamation of skin, anemia and jaundice, and it is more common in the malnourished people, and this is managed symptomatically by corticosteroid, and dapsone should be stopped temporarily. So fever, malaise, lymph node enlargement, jaundice, anemia and skin desquamation, these are the features of sulfone syndrome. And contraindications, so severe anemia is a contraindication because dapsone itself can cause hemolytic anemia. So already hemoglobin less than 7 gram %, it should be avoided. TCP deficiency and hypersensitivity reaction. So history of the sulfone syndrome or history of hypersensitivity to any other sulfonamide group of drug, then we cannot give dapsone. So what are the other uses? So dapsone is not exclusively used for the leprosy. It can be used in other diseases like in combination of the pyrimethamine. Dapsone is used in chloroquine resistant falciparum malaria. It can be used in toxoplasmosis in combination with pyrimethamine, and also can be used in pneumocystis jirovecii infection. Among them, toxoplasmosis is more common use. Falciparum malaria, it is not commonly used. Also pneumocystis jirovecii, we have better drugs. So toxoplasmosis is a good use of the dapsone. Pneumocystis jirovecii, it can cause pneumonia actually. Clofazimine, next drug. So mechanism, it has been postulated that it can interfere with the template function of the DNA, and it causes the alteration in the membrane structure and transport. It disturbs the mitochondrial electron transport chain, and thereby it is a leprostatic activity. So it interferes with template function, alters membrane structure and transport, and disturbs the mitochondrial electron transport chain. So it has leprostatic, and due to its anti-inflammatory nature, it can be used in other diseases also. A reaction called lepra reaction. So it is anti-inflammatory because it disturbs the mitochondrial electron transport chain. It is accumulated in macrophage, and half-life is very long, 70 days. Accumulated in other RE system cell also, reticuloendothelial system like liver, spleen, macrophage. It is stored there, and there is a gradual release of the drug from the store. And it is used in multi-drug therapy as well as in lepra reaction, and may be used in MAC infection, that is the mycobacterium apium complex. And clofazimine, if you remember the tuberculosis class, it can be used as, it is used also in the treatment of the MDR and XDR tuberculosis as second line drug. Okay, so clofazimine is a good option, and in leprosy it is mostly used in the multibacterial leprosy cases. Adverse effects, we have to counsel the patient about the reddish black discoloration of the skin, hair, body secretion. So often there is reddish black discoloration of the skin, and especially female needs to be counseled more because blackish discoloration of their skin is not acceptable to them mainly. Also, because just like rifampicin, we have to counsel the patient that there can be orange discoloration of the urine, but here as the skin is involved, so that is more striking, that is more prominent. That's why we have to counsel the patient well. Reddish black discoloration of the skin, hair, and body secretion. Dryness of the skin and itching, that can happen. Also, it can cause phototoxicity, just like dapsone, cause conjunctival pigmentation, and rarely it can cause pain, abdomen, weight loss. To be avoided in early pregnancy, liver and kidney damage. Okay. To be avoided in early pregnancy, liver and kidney damage. Next, rifampicin, a very important drug for the management of the leprosy, both multivascular and possibacillary, and it is a very potent, actually most potent cidal drug for the Mycobacterium leprae, and a single dose can kill 99.99% bacilli within 3 to 7 days. A single dose is 600 milligram. So in leprosy, that is a very slow growing bacteria, and this slow growing bacteria, a single dose of rifampicin can kill 99.99% bacilli, and it has been found that once a month therapy, that is sufficient to kill this 99.99% bacilli, and additional dose actually will not proportionately increase the killing rate of the lepra bacilli. That's why it is used at a very less frequency. That means once a month or once per 4 weeks it is used. Okay, because of the slow growing nature of the lepra bacilli. Lepra bacilli doubling time is 14 days, and it has been found that antimicrobials, if given at the double interval of the doubling time means number of bacilli, the time taken for the bacilli number to reach its double, and this doubling time is 14 days, and double of the doubling time, that is for 28 days interval, is sufficient to give the interval, and rifampicin can be given once per 28 days. If you remember the tuberculosis is a relatively rapid growing bacteria, and its doubling time is 14 hours, and for leprosy it is 14 days. So for adequate management of the tuberculosis, double of the doubling time, that means 28 hours, but interval should be maintained, and that's why it is given every day. Rifampicin should be given every day in tuberculosis, but should be given once per 4 weeks or once a month in lepra treatment. So skin lesions start regressing within 2 months, but it is not used alone, should be used with dapsone or clofazimine, but it doesn't reverse the nerve damage. It shortens the duration of the multi-drug therapy when combined with dapsone and clofazimine. So rifampicin introduction has drastically reduced the duration of therapy of leprosy. Just like if you remember the tuberculosis, pyrazinoate introduction has reduced the duration of therapy for tuberculosis. 600 mg monthly dose is effective but non-toxic and does not induce metabolic enzymes. So 600 mg monthly dose is sufficient to kill the 99.99% bacilli, and it has the advantage that as it is dosed very less frequently, so drug metabolism induction property with this low dose is not significant, and should not be given during reaction like erythema leprosum and liver cell reaction in leprosy patients. I shall discuss this reaction later. Ethionomide is another antitubercular drug, but it is hepatotoxic, so it is not used. Rifampicin is quite commonly used. So rifampicin, dapsone, clofazimine, these three are the mainstay of the therapy. If one or many of them cannot be used, then we have to go for other options. So what are the other options? We have ofloxacin as a component of MDT. It happens the bacteriological and clinical response. It can be used where rifampicin cannot be used, or to shorten duration of treatment. Dose 400 mg per day. Moxifloxacin, it is most potent fluoroquinolone against M. leprae, tried in some combination regimes with good clinical and bacteriological results. Minocycline, that is a tetracycline group, it is highly lipophilic, so penetrates the leprobacilli very well, and antilepratic activity is between rifampicin and clarithromycin. It can be tried in alternative multi-drug therapy regime, and vertigo is the only serious problem. And clarithromycin is the macrolide. It is tried in alternative MDT regime also. Dose is 500 mg per day, and it has synergistic action with the minocycline. Now, classification of leprosy is important, because classification after classification, then we can select the therapy for each patient. Possibacillary leprosy and multibacillary leprosy, depending on the number of skin lesions and depending on the number of nerve involvement. So possibacillary leprosy means persons having 1 to 5 skin lesions and or only one nerve involvement. And multibacillary leprosy means persons having more than equal to 6, that means 6 lesions or more means multibacillary leprosy. Up to 5 skin lesion is possibacillary, and only one nerve involvement is possibacillary, and more than one nerve involvement is multibacillary. So adequate treatment means completion of regimen of multi-drug therapy. For possibacillary, 6-month therapy is given, and that can be completed within 9 months. So it has leprobacilli being slow growing bacteria. Even we miss 1 or 2 months therapy, that is not very harmful. So 6 months therapy can be completed within 9 months, and 12 months therapy for multibacillary leprosy is given, and that can be completed within 18 months. So defaulter means who have taken the drug irregularly or not completed the treatment. So a patient on multi-drug therapy who has not received treatment for 12 consecutive months, we call them as defaulter. Whereas in tuberculosis, if patient do not take the medicine for 1 month, he is a defaulter. Relapse case, patient who after completion of an adequate course of MDT subsequently develops new signs and symptoms of leprosy. So relapse is common in leprosy patient also, but the treatment remains same. We have to start the therapy again for multibacillary, possibacillary leprosy depending on the nerve involvement, depending on the number of the skin lesion. So national program is there. We call them as National Leprosy Eradication Program from 1982. Previously it was National Leprosy Control Program. So as we have achieved elimination means less than 1 per 10,000, that is the incidence. If we can, as India has less than 1 per 10,000 incidence, then we have actually achieved elimination, but still cases are there. So eradication is our next goal. That's why this treatment, the national policy is called Leprosy Eradication Program. And following initiative under WHO Action Program for the Elimination of Leprosy, India introduced multi-drug therapy for leprosy through NLEP in 1982. And in December, elimination is achieved. Prevalence is less than 1 case per 10,000 population. So what is the treatment for multi-drug therapy for regime? In multibacillary leprosy, we give rifampicin 600 mg once a month supervised. Supervised means patients have to take the medicine in presence of health care worker. Then dapsone 100 mg daily self-administered. Patient needs to come once a month to collect the medicine, and dapsone is self-administered, but rifampicin is given taken under supervision. Clofazimine, this is given only for the multibacillary cases. So for multibacillary, only 600 mg monthly rifampicin and 100 mg daily dapsone is the treatment. For multibacillary leprosy, additionally we give clofazimine. Clofazimine, both types of dose are there. One is 50 mg daily self-administered, and one is 300 mg monthly, that is supervised. So for multibacillary leprosy, two supervised step medicine. One is rifampicin 600 mg and clofazimine 300 mg, and daily medicine dapsone 100 mg, clofazimine 50 mg. And for possibacillary, only rifampicin is supervised monthly, and dapsone is to be taken daily. Duration of therapy for MDT, multibacillary leprosy, it is 12 months, and for possibacillary leprosy, it is 6 months. So what is the advantage of this combination therapy or advantage of multi-drug therapy? It is effective in case of primary dapsone resistance. Also, multi-drug combination actually prevents emergence of the dapsone resistance also, and symptomatic relief is quick. So clean lesions appears regressing within 2 months. It renders the patient non-contagious rapidly, that is the benefit to the society, and it reduces the total duration of therapy, that is benefit to the patient. So duration of therapy is reduced, patient is made non-infectious rapidly, and also symptomatic relief is quite rapid and prevent development of the resistance. So these are the advantage of this multi-drug therapy in leprosy. The points to remember: 1 year fixed duration therapy is considered adequate for most multibacillary leprosy cases, but if patients relapse, again multi-drug therapy is reinstituted. And where feasible, treatment till cure of the individual patient should be ensured both in MBL and PBL cases. So often it has been found that 1 year therapy is not sufficient to cure completely. But national policy advocates 1 year therapy, because after that patient is non-infectious and there is little chance of spreading of infection from the patient. But as there is little chance of relapse in the patient, so if patient can afford, but because after this 12-month therapy, government will not afford your treatment, patient treatment, but if there is incomplete cure, if patient can afford, then this therapy can be continued for few more months. And few relapses cannot be prevented irrespective of duration therapy or the drug used due to persister bacilli. So some persister bacilli will be there, and they are slow growing, and that's why even it has been found that even after 5 years of continuous therapy, complete cure may not be achieved. That's why it is personal choice how long patient will continue the therapy, but 1 year is quite adequate. But if patient works, then we can continue the therapy for few more months. So blister pack is available that contains 28 day treatment, that is available free of cost for all MBL multibacillary leprosy cases for 12 months, and such 12 packs have to be consumed within them by 1 year. Separate blister packs are given for possibacillary leprosy cases, and 6 such packs are to be taken by each patient. What are the alternative regimes? So alternatives are used when either of these rifampicin, dapsone or clofazimine cannot be used, and one of the popular regime is ROM therapy, that is called intermittent ROM. ROM is rifampicin, ofloxacin, minocycline. Rifampicin here given 600 mg once a month, ofloxacin 400 mg plus minocycline 100 mg once a month for 6 months in PBL, and 12 to 24 months in multibacillary leprosy cases. So it is given either when dapsone cannot be given, or due to intolerance or resistance, or when clofazimine cannot be given. So for rifampicin intolerant patient, so if rifampicin cannot be tolerated, then treatment is a little bit complicated. Then we can give clofazimine plus any two of ofloxacin, minocycline, clarithromycin for 6 months, followed by clofazimine 50 mg plus any one of these ofloxacin, minocycline for 18 months. These are the other options. You need not remember all. Moxifloxacin 400, minocycline 100 mg, rifampicin 600 mg once a month for 12 months. So remember this ROM therapy, and rifampicin resistant patient or intolerant patient, we give clofazimine plus those alternative drugs like ofloxacin, clarithromycin, minocycline. In dapsone intolerance, for MBL, no other drug is substituted for dapsone, because we have to go to the ROM therapy or the clofazimine based therapy. But if for PBL, as in PBL possibacillary leprosy cases, as clofazimine is not given normally, here we can replace dapsone with clofazimine. So standard clofazimine dose is given in place of dapsone along with monthly rifampicin. So for PBL, if dapsone is resistant or intolerant, then treatment is easy. Just give rifampicin plus clofazimine. But as MBL patients already receiving dapsone plus clofazimine plus rifampicin, as dapsone cannot be given, then we have to go for the other regimes like ROM therapy or clofazimine plus minocycline, clarithromycin, that therapy. And clofazimine resistance, in MBL cases, clofazimine is substituted by ofloxacin 400 mg daily and minocycline 100 mg daily for 12 months. Okay, and or we can give this ROM therapy again once a month for 24 months. So ROM therapy is quite good because once a month therapy that makes these triad patients very comfortable. Next, apart from leprosy, after introduction of leprosy, two types of reactions can happen. One is called lepra reaction, one is called reversal reaction. So lepra reaction is Jarisch-Herxheimer type of hypersensory reaction, that is a type 3 hypersensory reaction. It is due to release of antigens from the killed bacilli, and more severe reaction is called erythema nodosum leprosum. It is type 3 hypersensory reaction and occurs mostly in the lepromatous leprosy patient and coincides with the institution of the anti-leprotic therapy, and rarely it can cause life-threatening infection like erythema nodosum leprosum. It is quite onset is quite abrupt and existing lesions enlarge, become red, painful, swollen. So just after introduction of therapy, it can happen. It is a type 3 hypersensory reaction, mostly due to release of the killed bacilli, and that can cause some hypersensory reaction, that is type 3 hypersensory reaction. So existing lesion enlarge, become red, painful, swollen. There can be marked malaise, fever, and rarely new lesions may appear. So this is the picture of the erythema nodosum leprosum. In severe cases, it can be life-threatening also. So what is the treatment? Clofazimine 200 mg daily as anti-inflammatory dose. So normally clofazimine is given 50 mg per day as anti-leprotic dose, but when there is this lepra reaction, clofazimine as anti-inflammatory, it is given in 200 mg per day. Prednisolone is the drug of choice. Prednisolone 40 to 60 mg per day with gradual tapering over 12 weeks. So firstly, suppose if prednisolone is given 60 mg per day for first 2 weeks, then it is gradually doses tapered 40 mg, 30 mg, 20 mg, 10 mg, 5 mg like that for 2 weeks each, and gradually we taper the dose within 12 weeks. Thalidomide is another option, can be given in erythema nodosum leprosum. Multidrug therapy is usually continued, and temporary discontinuation of the dapsone is required only in the severe cases. Chloroquine is another option, and mostly it is managed symptomatically by analgesic antibiotic like NSAID. Okay, so what are the options? Corticosteroid is the drug of choice. We can give clofazimine, we can give NSAID, we can give thalidomide, we can give chloroquine in the lepra reaction. Next is reversal reaction, that occurs late. So lepra reaction, existing lesion enlarge, become painful, patients have fever, and it is generally started after a few days of therapy. Reversal reaction seen in the tuberculoid leprosy and the borderline cases, whereas lepra reaction most common in the lepromatous leprosy cases. Reversal reaction is a manifestation of the delayed hypersensitivity, that is a type 4 hypersensitivity reaction. It causes cutaneous ulceration, multiple nerves become tender and swollen. It can occur suddenly even after completion of the therapy. So it is not existing lesions enlarged, but often the lesions, there is ulceration and often nerves become tender. Symptomatic treatment done with corticosteroid and clofazimine. Thalidomide, chloroquine, these are not effective. So corticosteroid is the drug of choice for both lepra reaction as well as reversal reaction. Remember this. Thalidomide is another option. It has multiple other uses, not needed now. So treatment in pregnancy and lactation, MDT regime is considered safe and thus advised to continue unchanged during pregnancy. Though small amounts are excreted in breast milk, there is no report of serious adverse reaction in mother or baby with continuation of breast drugs during lactation. So all drugs can be continued during lactation also. So two questions: why is rifampicin given once a month only? Why clofazimine given once a month in addition to daily dose? So these are the two explain why questions. The first question already discussed. Rifampicin is an exceptionally potent bactericidal drug against Mycobacterium leprae. Single dose of 600 mg is capable of killing 99.99% bacilli, more or more of the viable organisms, and rate of killing is not proportionately enhanced by subsequent dose. So if we give rifampicin once a week or once every 2 weeks, then there is not proportional killing because single dose can kill 99.99% bacilli. And it is also possible that rifampicin exerts a long post-antibiotic effect for several days, during which the organism is incapable of multiplying. So it has long post-antibiotic effect, organism is incapable of multiplying. Also, leprosy is slow growing bacilli. That's why doubling time is 14 days. That's why if we space this drug at the double of the doubling time, then that is sufficient to kill most of the bacilli. And clofazimine, being a repository drug, it is stored in the body after administration and is then slowly excreted, because it is stored in the reticuloendothelial system, liver, spleen, and it is given as loading dose of 300 mg once a month to ensure that the optimal amount of clofazimine is always maintained in the body tissue, even if patient misses one or his or her daily dose. So daily dose is also given, but if patient misses some of the doses, then this 300 mg dose, which is given as a supervised dose once a month, that can ensure that adequate level of clofazimine is still present in our body, and that can cure the multibacterial leprosy well. Okay? So this is the treatment for the leprosy.